Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th annual conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Oh, thank you, Debbie. It certainly is a pleasure to be with everyone here today. So this session is entitled Innovating with AI Applications in Health Data. This session was organized by Brandi West, and today's moderator will be Chaz Busenburg. The session is sponsored by Stone Transformation, and I'd like to turn some time over to Chris Odell from Stone Transformation to introduce today's session. Chris?
Good afternoon, everyone. And thank you for joining this session, Innovations with AI, Applications in Health Data. My name is Chris Odell, and I'm a director at Stone Transformation. We're a boutique women-owned consultancy focused on navigating the human side of change, with a particular focus on supporting the use of AI for data-driven decision-making and policy. It's really a privilege for us to sponsor today's discussion. You know, we all know AI has opened extraordinary possibilities across health data, not just in speed or scale, but in meaning. It helps us make sense of disparate data sources, draw on novel insights that might take weeks or months to uncover through traditional methods, and helps us translate complex findings into clear, compelling stories that people can act on. When done well, AI doesn't replace the human element of interpretation, it strengthens it, helping analysts draw deeper insights, policymakers tell more powerful stories, and leaders see what matters most faster. And of course, the real opportunity comes from linking data sources, not from collecting more data, but from connecting it. When we bring together claims data, program data, social determinants, patient experience information, and the like, we can uncover new patterns. We can benchmark performance in more meaningful ways and ultimately unlock insights that drive better care and smarter policy. But as we'll hear about today, realizing the value of AI takes strategic planning, oversight, and ongoing management different than traditional technologies. It means preparing your data, ensuring quality, structure, and consistency before automation ever begins. It means designing tools that are genuinely useful to the people who use them. And it means, most importantly, bringing others along through this transition, helping teams understand and trust the insights that these novel systems produce. At Stone Transformation, we see these challenges and opportunities every day, helping organizations integrate data, build robust data architectures to unlock their analytical capabilities, and establish governance frameworks that make innovations stick. See, our work sits at the intersection of technology, strategy, and the human side of change. And that last element, the human element, we find is the most important. So I'm really looking forward to today's session and to learning from these incredible speakers about their experiences applying AI to APCD, HIE, and other health systems data. We're really proud to support NAHDO and this remarkable community of leaders, analysts, and innovators who are shaping the future of health data. So with that, let's get started.
Thank you, Chris, and thank you for your sponsorship. So let's go ahead and bring Chaz on stage. Chaz, how are you today?
Good. How are you doing, Norm?
Great. All right. Well, I'm going to turn the time over to you, and let's go ahead and get started.
Yeah, absolutely. Hey, everyone. My name is Chaz Busenburg. I'm a senior manager of data and AI with Milliman MedInsight. I'm excited to bring 4 really great presenters today to talk in front of you about a couple different topics. Ernie, Shippey, Devon, Holgate, Dominic, Gayton, and Bill Balderaz. We're going to start with Ernie and his linking new technology to claims data with AI. Please, one we heard the note earlier. If you have questions during this, I'll be keeping an eye on the Q&A. Really want to give some time to engage after each of these presentations. So please feel free to send those in. I'll be keeping an eye on them. Excited for what we've got for you today. All right.
Hello, my name is Ernie Shippey. I am a research director with Vizient, and I'm here to talk about the use of AI in clinical research and evaluating new technology adoption. There's a lot of reasons why we need to use AI. The biggest one, I could take all these different points, is really about these very large big data sets with longitudinal data to link those. Doing those types of queries really requires AI to actually build those efficiently and effectively. The analysis we did was on new technology. As you know, most new technologies, they all start with a clinical trial, then it gets approved, millions of dollars are spent, and we get real-world adoption. And this is where our hospitals really want us to look at. As the new technology is adapted in the real world with real cases and is expanded among different presentations, are they still effective compared to the clinical trial? Our big AI use is ChatGPT. We built a private network where we upload our data schemas and our different methodologies. This is key for us and has been a great tool over the last 2 years. I'm going to show you some of the sample ChatGPT prompts. Here we built a charge master and we uploaded the data and asked it to go ahead and build keywords. Here we go, we got the data back. It actually gave us the keyword frequencies right here, so we can start to review the data. Adopting and scaling is one of the most important things. We can't just be building spreadsheets and dropping them into ChatGPT. So quickly, we can ask it to go ahead and write the query for us that it used to actually do the analysis so that we can put it on our database and run it for all 25 million charges. It ran very quickly. We can start to look at the different, how it broke out the description into separate keywords. The review, we can check every single item if we wanted to. The real beauty of the AI and the Databricks environment is in the deep linking. We quickly took a bunch of charge codes, put them into product lines. So we took it from free text into categories. We can add the patient procedures that were done, and we can really start to look at computer-assisted thrombectomy for stroke patients at a much more deeper level. So now that we have all these matches done, we want to start to add some validation. We know there's going to be false positives. In any type of this type of analysis, you're going to find those. So we can quickly start to look at where imaging things accidentally coded into pharmacy or infusions. So we can start to really look at these and correct them. And that way we can take the outputs of any of them that look like they're mismatched, send them to a human and have them evaluate them, flag those, and then the engine will relearn the information as we expand upon the rules and the validations. A nice feature of the AI is in really curating the data. For those of you who have done a lot of clinical research, we have to create one encounter per patient with all the different variables pivoted out. So we can quickly go in there in the ChatGPT, point it to our comorbidity table and say, please pivot out all these into 17 different variables with 0 and 1 so that we can actually use that in our multivariate model. This becomes so nice just to eliminate doing that type of pivoting. So it can actually rebuild those. We can start to add other variables. We can add the other demographics, the different outcome measures that our clinical SMEs have told us to add. And we can quickly ask ChatGPT to go in there and actually document, look at the code that we've written, take all the code, go ahead and create a white paper on what the research protocol was based on the logic that we used. It can even add comments into the code. So as we revise it, maybe next year we're going to repeat this study, we can actually go in there and look at the coding and see what we did. And we know, oh, there's some new codes that we need to apply here. we can quickly do that. Here's a sample outcomes analysis that we did. It was for heart failure, and we're looking at the new drug usage using the SGLT2 inhibitors that protect the kidney, the GLP-1s that help with diabetes and weight loss. And we really wanted to look at the impact on heart failure, which originally wasn't the intention of using these drugs, but now has expanded as we've seen as it gone through clinical trial, that these protective effects are really good in other cardiovascular conditions. Heart failure is very severe. We can see a 2.8% inpatient mortality. Within 30 days, 10% of the patients will impact mortality and 17% readmissions. We start to see these protective effects 38% lower using the SGLT2s. We also see significant protection with the GLP-1s. We did look at other things like his age, race, payer, length of stay, ICU stay, all these other variables. Interesting interactions was on SGLT2 inhibitors, which are there to protect the kidney and chronic kidney disease. They still provide quite a bit of protection, even in those that are already have compromised kidney function. Same thing with GLP-1s and those that are obese. We start to see that it's even providing protection for those, even though they are still obese and still using those drugs. So we're seeing these really good protective effects that are really starting to inform the clinical conversation, because both of these drugs had nothing to do with cardiovascular conditions when the clinical trials were released. But now we're seeing this massive adoption in those that have compromised cardiovascular function. Another outcomes analysis sample that we did was on the use of smart beds in hospital-acquired pressure ulcers. We know that this is a really big concern. There's $26 billion spent annually to treat these patients. So we're looking at the use of these smart beds to really see how much they're actually impacting. It's a multivariate model, so we have all these other conditions. And we really start to see that it's a 19% lower association of having a pressure ulcer with the use of these beds. We start to see other factors as well. We can start to see malnutrition. Interesting finding was one of the largest predictors of a pressure injury. And we start to notice these outcomes, and we start to see where we can impact it. Because a lot of our hospitals are looking at, should we start to invest in these smart beds? What patient population should we invest in? So these are all really valid concerns, so that we can start to do sub-analysis type questions. We could actually look at this analysis, which we know is significant, and we can start to break it down and let them know what patient cohorts, how many different types of patients are being treated for these diseases and these adverse outcomes and how they can impact them. We completed this analysis on 382 emerging technologies, new ones each month. We found 17 technologies like the two that I showed you, where we're starting to see much more improved outcomes, even better than what the clinical trial showed, as it's hit the real world. Unfortunately, we've also seen 31 that are really starting to underperform compared to the clinical trial, which requires much more sub-analysis, new research questions, so that we can actually start to find out how is it possibly being misapplied. So all in all, we've learned a lot about the workflow. One great thing it does is when we can do these statistical analysis, we can send it through ChatGPT, have it look for any biases that we might have introduced into the model, any assumptions that we made, and basically have it kick the tires for us. It's really great at that. It's also a great documentation tool. It'll actually quickly build a research protocol based on the coding that we've done, so we can compare it to our intended research protocol and actually tell it to actually compare the two and see if we got it right or if we made some mistakes. We also learned a lot about language modeling. This is the one area that's so complex. The English language is complex, right? But we start to see semantic drift and what we call toxic merge, where different concepts get associated that shouldn't be. And that's where we have to bring in the human and the experts to actually help teach the AI how to learn. We also learned a lot about how analysts can use this data and how well they adopt to it and how important present on mission coding is, much more than what we had thought before.
All right. Hey, Ernie,
Hey,
great
Chaz.
presentation.
Thank you.
Appreciate your time. One of the things that I think most people, if you've been getting really heavy into claims or you've been getting really heavy into AI, you're seeing a lot of that using AI to help us create code that, or in your case, using AI almost for machine learning experiments and designing those machine learning experiments. Would you be willing to go a little bit deeper into how you manage? I know everyone here, we hear in the news feels like every day, like hallucinations. Would you be willing to go a little bit deeper into how you've kind of managed that in the design of these machine learning experiments using AI alongside it?
Yeah, so a lot of times what we have to do is we have to put a lot of quality controls into it. So we usually started off with a lot of our clinical champions. So we'll work with a lot of the docs that are in this area. We might have a collaboration where we have 20 different departments that are looking at smart beds, and we'll talk to those different officials. We'll start to say, what are some checks on here? Some of those hallucinations that happen all the time. And a lot of it's really that semantic drift that goes on. And we start to see, Apple, does it mean an Apple computer or does it mean the fruit? So we add a lot of those checks in there, especially when we're looking at a lot of the clinical data. We've actually started to build really nice libraries where we can look at, TPA is a type of thrombolytic that's used on stroke patients, but we can see sometimes it gets confused and thinks it's tape. So a lot of times we're going in there and we're constantly correcting it. So I think it's the real beauty of it is we start to look at it and then we start to present it to the clinical experts and we start to just keep adding to those dictionaries and libraries and adding more corrective coding to it.
Somebody had a really great question around steps regarding data security. I know this is something that I get hit with all the time. How are we handling AI with data security? And I'd be really interested in your perspective on that.
So we added quite a bit. So our chat GPT is locked down. Um, we had to go through specific security training for it. Very similar when we use some of the data from CMS. A lot of these systems end up becoming very locked down. So we have to go into our data queries, and then we have to be able to separate it and put it into another environment for the chat GPT. So we do have a lot of firewalls that are built within our warehouses so that we can control that, just because we don't want anything floating out into the public one. So our company's really locked down our chat GPT and our AI to limit it from getting spread out into the public ones. Like if we accidentally go into the public chat GPT, it gets locked down. But the good part about that security is it starts to learn our schemas and it starts to look at how I like to write code and how I like to build a patient cohort. And it starts to suggest patterns that you've already used before. So for every user we have, it started to learn your style. So I think that's how we handle security is really, it's greatly locked down, but it is very good at actually allowing us to do as much as we can in that protective environment.
Yeah, we found very much that like it being able to learn around about the schemas, the columnar descriptions, all those pieces gave it a lot. And you're protecting the data by not giving it access to data, but much more towards writing those SQL queries or writing those queries against it. And creating those separate environments really does help to learn those schemas, but then you're not letting it see that data quite as much. Pretty cool.
Yeah, we don't. Yeah, we don't allow it to do that. We have to build very small snippets,
Yeah.
and we actually go through a data governance thing to actually before we would even upload a schema, it goes through our data governance team.
Martha's got a good question. Would you be willing to expand on your place of service use in your models?
Yeah, so we have different places. I'm not sure if it's place of service on the claim. Is that
I'm
or the
I'm
code?
guessing how does this get out to providers, or how does this get out to decision makers when you've created this model? At least that's how I'm interpreting it. How do you take action?
Okay, so we typically will do the data modeling, and then we will typically do the biostats. So that's where my department comes in. We'll run a lot of the biostatistics, and usually it goes through a lot of iterations. So we'll bring our collaborative team together. We'll start to review the data, and we'll say, here's what we notice. And then typically, I'm going to be honest with you, it goes through about 4 to 7 iterations before we get it right. Typically, a lot of times the clinician will say, wow, that's really good. What else did the machine learning find? Well, we found out, you know, this drug, for example, like with a diabetes patient, when they're only on metformin, it's typically a lower risk. As soon as they're on basal insulin, a much higher risk. So we start to go through and we run the statistics and we share those multivariate models with our internal team. And then we even create a little, what we call a sandbox, where they can go in there and they can actually start to tweak it. Um, that happens a little bit, not as much as I would hope for, but it creates a really great conversation because they really start to understand how the AI is adopting. And then a lot of those interactions that we found, we went back and told it, what are some of the interactions that you would like to see? And then the clinician really just put it in there and we just plugged it into the box and it actually changed we did Alzheimer model last month. It actually went in there and we said, we want to make these 4 changes in the model. It actually rewrote the code. We could test it, run the biostats, and see how well it worked within literally 3 hours.
That's pretty cool. All right, we've got a couple more presentations. Ernie, I want to thank you for
Yep.
coming in. We'll invite you back a little bit later to chat. I know we're getting a lot of questions. Just want to say thank you for bringing those up. We'll have some time towards the end, hopefully, to be able to answer some more of those. We're going to move on to our next presenters, Devon Holgate and Dominic Gayton from Onpoint Health Data, talking about AI meeting APCDs.
Hi, everyone. My name is Devon Holgate. I'm the Chief Technology Officer at Onpoint Health Data, and I'm joined by Dominic Gayton, one of our data analytics managers. And we're going to be talking about AI assistants or AI chatbots and how they can be leveraged for analytic use cases. And specifically, we'll be looking at public use cases such as healthcare transparency. I'm going to start by doing a quick overview of what do I mean by AI assistants and how can we build those. And then I'll hand it off to Dominic to show what it looks like in action and talk about some of the pros and cons of using. So to discuss kind of what do I mean by an AI assistant, really we're talking about generative AI applications here. And all of those are built on what are called foundation models. These are large language models that have been pre-trained on large amounts of data so that they have general knowledge and can converse in natural language and be leveraged to address a broad set of tasks. So some of the big names that you might be familiar with in this area are GPT, Claude, and Gemini. There are many others out there, but these are the big ones. With these foundation models, we can build on top of them and create AI agents. Kind of the most popular way to do that is something called retrieval augmented generation, or RAG, where we provide some context to this model, typically through a system prompt, which will give this model a role and tell it how to address certain types of inquiries that it might receive from a user. And this is just an example system prompt, very brief, but these can be very detailed. Many of the major models these days support up to 1 million tokens, which you can roughly equate to 1 million words. So just through a system prompt, you can give quite a bit of instruction to the foundation model. Along with those system prompts, we can give access to a variety of tools for that model to work with through a process called tool calling. Here I've listed out some of the most popular tool calls that are being used in the industry currently, such as database queries, vector stored lookups, which is leveraged to pull out pieces of documentation, web searches, API calls, and a variety of other types of code executions. Worth noting, you also call other agents through this same process. So in packaging all of this together, you create an agent that can do some really impressive things in answering queries for users and handling a variety of tasks. So that's already powerful in and of itself, but it becomes even more powerful when we take multiple agents together into a multi-agent architecture where we specialize certain agents in different areas so they can give even better responses for those targeted areas. So to demonstrate what that might look like, I'll take an agent, I'll give it a role of a planner that kind of plans out all the tasks that need to be performed when a request is received. So when I receive a request, in this case, a question, such as what are the top 5 most expensive procedures in the data, the planner agent would then take that and break it down into various tasks and reach out to one or many agents to perform all the tasks that it needs to, such as perhaps querying a database. Those responses would come back to the planner, and the planner would then summarize that and give back an answer, a single answer to the user. So that's just a quick overview of how these multi-agent systems work. There are many tools out there that you can leverage to build solutions such as this. I've kind of bucketed some example solutions into 3 different areas. So one is the big piece is the actual LLM that you choose to use. Another big piece is where do you want to host this type of solution? You can do that directly within the model providers such as OpenAI or Anthropic, or you can host it in any of the major cloud providers. There are also helper frameworks out there that you can leverage to build the logic and the flow of these agents. And I've just listed a few here, and these are getting better and better every week. New tools are being created as well. So with that, I'm going to hand it off to Dominic to show you this in action and show you how you can leverage this for an analytic use case.
Thank you, Devon. So I'm just going to talk a bit about how we would use this technology for healthcare transparency reporting. But first, I want to talk about one of the common methods we would use today for healthcare transparency reporting using the APCD data, and that is to build a dashboard. And dashboards have many pros. For example, you can see that this dashboard is showing a lot of data in one view. If you're a savvy user, you can easily find what you're looking for with a dashboard. You know your way around. But they have some cons as well, and this is particularly true with relation to the general public that might be using public transparency reporting to understand what they might pay for healthcare. So for example, this dashboard is a little complex. It might be intimidating to the general public, or there's also a lack of an ability to have a natural language interaction with this dashboard. So if you don't know exactly what particular type of drug you're looking for example, in this dashboard, you might not find your way to it. That's where this LLM technology that Devon just described comes into play. This allows us to create a whole new experience for this type of public transparency reporting. It starts with just simply putting a question into a chat experience, just like we're used to doing with messenger apps or with ChatGPT. You send that question off to the agent, and right away you get an answer. And the answer is written in natural language. It even asks you a follow-up question, so you can continue the conversation. If there's something different you want, you can ask it for more context. So as you can imagine, if we're using this data with, or if we're using this technology for reporting on sensitive health data, people might be using this data to make decisions on their healthcare. We want to make sure that we're mitigating risk to the greatest degree possible. And so as we've been working with this technology ourselves, we've come up with a few best practices that we would recommend others use as well. For example, setting guardrails. This prevents the agent from straying off topic or into forbidden domains. Setting up evaluation systems to make sure that the model is working as expected. in an automated manner. And also displaying prominent disclaimers and doing that in the user interface for the chatbot experience, not in the LLM itself, so that the LLM can't put its own spin on disclaimers. So with that, I'll pass it back to Devon for some closing thoughts.
Thanks, Dominic. And as a quick recap, we're really excited for what AI assistants like what we just showed you can do for analytic users, particularly for those who are less data savvy, such as the general public. And we're expecting these to become more and more important in data dissemination as they become easier and easier to build. We thank you for your time and look forward to your questions.
Awesome. Well, thanks, Dominic and Devon, for hopping on. I know we've got a couple questions that are coming up. I had one specifically before we have some others come in. One of the things I've been really interested in is especially around you. I know, Devon, you mentioned RAG implementations or other AI agents. And there's some of those ways that we might be able to mitigate privacy concerns. Do you feel like some of these AI agents can help us navigate those privacy concerns? And how do they do that for us?
Yeah, sure. I can take that. I think there's a few areas of concern around privacy for AI agents in general. So maybe I'll talk about that from like a high level. What are the concerns and the ways to mitigate them? One is around like the example that I gave of querying a database. So if we're giving access to data to an AI agent, how do we make sure one of these AI companies isn't training their own models off of that, or how do we protect that? So there are ways to structure a solution so that you house all of that within your infrastructure. You don't have to reach out to a third party to do that. You could do that in a cloud provider. Many of them host certain models, not every model, in that way. So you could choose your architecture to make sure that you're building in a more safe way. The other area for privacy concerns is around that chat interaction. So you can't really always know what a user is going to put into a chat. They might divulge more information than you're expecting. So there are things that you can build into your solution to make sure you're not storing anything sensitive long-term from those messages, even though you do want to glean some information from them to make sure you're continuing to provide a good service.
Awesome. Looks like Chris made a mention about some of the multi-agentic systems, and it kind of leans in a little bit towards the human in the loop processes versus maybe LLM as a judge. And so I wanted to kind of ask you, Dominic, if you'd be willing to talk a little bit about the balance between those two when we're talking about these multi-agentic systems.
Yeah, that's a great question. So one of the things that we've been working on in terms of human in the loop is when we have a chat user interface, something you might be familiar with from different tools that are available, ChatGPT, etc., is that you can have a little button where you can either say, you can rate the response that the model gave as good or bad or positive or negative. And something that we've been experimenting with is capturing that data along with a full log of all of the sort of decisions that the different agents made and the rationale that they provided for their different decisions. The logs are really highly detailed. So we can take those two pieces of information together and we can track them over time. And that thumbs up, thumbs down user interface is one of the key ways that we are thinking about this human in the loop way of doing it. But that also goes along with the LLM as a judge methodology, which is really helpful and produces really good reporting that, of course, is looked at by real staff and to make sure that the model is working correctly.
Awesome. Have you found ways? I'm going to open this one up to both of you. Are there any public-facing examples of how AI chatbots have been incorporated into the APCD transparency tools. Julie mentioned this in the questions below, and wanted to know if either of you had heard of public-facing examples.
I can take a first crack at that. I'm not aware of any current public examples that are out there, but we do work with our clients and know that there are several of our clients are interested in this, and hence why we're working on these types of projects to help support that.
And then I've got one last one for you before we hop off. Have you found ways to quantify hallucinations? I know that's a little bit back into the LLM as a judge and a little bit as the human in the loop, or using other tools like maybe Llama Guard or some other specific models for putting in guardrails, just generally. Any thoughts?
Sure, I can get started, and Devon can pick it up from there. I think that one of the main things that we're doing right now is making sure that we're capturing the data and storing it so that we can analyze it down the line. Of course, the reports that come out of the LLM as a judge methodology will give you a quantification of all the different tests that have failed. And then as we capture a larger sum of data for use by the general public, I think we're thinking of ways to analyze that. Anything you'd add to that, Devon?
Yeah, I think the best way is probably at this point is that LLM as a judge. So the way that typically works is you use another LLM to evaluate if the response that the current solution is providing is the same in content as what you're expecting. So you can give that judge some expected answers, known answers that you want to receive. And then if it deviates, if your solution deviates, that LLM will flag that as a potential issue. So that could be a hallucination, or it could just be not providing the information that you're expecting it to.
Yeah, we found certain metrics like does it respond in a professional tone? Does it end up giving an answer that aligns with kind of what we were expecting with the core source answer? But then also just like, is it answering something that we don't want it to, right? Like we don't want to give clinical advice somewhere. Typically not a great idea. And so having that LLM as a judge being able to guide that really does help. I want to thank both of you for hopping on, Devon, Dominic. I appreciate your time, and we'll talk with you in a few minutes. This is a great time. I know Norm mentioned in the chat, if you haven't done the polling, we'd love for you to please answer that poll. It should be available in the polling section on your event. We're going to move on to our next presentation with Bill Balderaz and Charlotte Wilson, talking a little bit about innovating with AI and their applications in health data.
All right, thank you for having us today, NAHDO. We're very excited to be here. Today, we're going to talk about how you can prepare your healthcare organization and, more importantly, your healthcare data to get accurate and meaningful information and analysis to help drive your organization. I'm Bill Balderaz. I'm the CEO of Futurety and HUCKLE. We help healthcare organizations and hospitals across the country to engineer, organize, visualize, and make great decisions using their data.
And I'm Charlotte Wilson. I'm the principal consultant for Char Wilson Consulting. So here are the two items we'll cover today. We'll talk about 5 roadblocks to preventing that accurate and meaningful analysis. And then Bill will walk through a case study of Prairie Bridge Health Systems demonstrating what it looks like when you can remove those data roadblocks. So here are the 5 data roadblocks that we'll talk about today that are really preventing an accurate and meaningful analysis for organizational success. Let's go ahead and hop into it. Roadblock number 1, fragmented data. This means your information is scattered across multiple disconnected systems, platforms, and databases. You really lack a single unified view, and that prevents you from having a cohesive understanding of patients, campaigns, or your business performance. Some things that you can ask yourself when you're thinking about how you can address fragmented data. Ask yourself, can I easily combine data from different sources? How is my data being collected and connected? What's the quality of my data? And do I understand what's inaccurate or incorrect and missing? To take action on this, just focus on 3 to 5 high impact data points first, and focus on bringing those together. This is an issue we all face. It can feel overwhelming. If you focus on 3 to 5 high impact areas, it's a great place to start and start to have some success. Next, tool immaturity. This is when you have the absence of appropriate technology or personnel required to perform reporting and analysis. Often when you have this, you end up relying back on manual processes or generic software. So start to tackle this issue. Ask yourself, do I understand the analyses and reporting requirements that I support? It sounds really simple, but sometimes just stopping and asking yourself that question might be surprising. Then think about, are there other teams or individuals with similar reporting needs? What other software may have already been improved in the organization? Oftentimes, taking a few moments to think about these things may reveal some interesting findings in terms of other similar problems that other teams are solving. When it comes down to this one, make sure you're opting for accuracy and consistency over ambition when you're taking action. There are lots of tool sets. They're going to grow and change over time. Stick with your core tools and add on from there, making sure that they integrate well. This is one to watch closely because AI and the growth of AI is going to change this significantly in coming years. Roadblock 3, lack of stakeholder alignment. This is when you're really dealing with that, lack of unified view around your patient data strategy. This results in conflicting priorities, competition for resources, and fragmented efforts. A few things to ask yourself when you're addressing this issue. Is there alignment within your team regarding reporting and analytics priorities? Do I understand what's important to the other partners and what they need? What are some shared goals that we can come together on? When taking action on this, first think about aligning on priorities within your team so that you can clearly communicate to others what your team is working on and what's most important. Then you can start to align more successfully with others. Roadblock number 4, gaps in governance. This is reporting governance, rules, processes, the way that you're going to create, distribute, and use reports and data. The purpose is to make sure that people feel that they are getting consistent, accurate, and trustworthy information from you and others within the organization. In order to address this, ask yourself simply, what are your data definitions? How are they similar or different from other teams who might use similar or related data in other departments? Ultimately, who's accountable for data accuracy? Again, on this one, it can feel overwhelming. Just identify 3 to 5 critical metrics to document for better understanding, and then add from there. Finally, absence of patient trust and compliance. This is one that we know well. It's that confidence that our patients know that we're going to act in their best interests regarding ethical and secure handling of data, and that includes our mandatory adherence for legal and regulatory requirements. So ask yourself, does your patient experience and communications offer data transparency and indicate a responsible use of data? And are you making it easy for patients to indicate their communication preferences? When it comes to action, think about the way that you audit your processes. We're often auditing processes for high-risk activity around compliance, but what about patient trust? Make sure that you're addressing both when you're working on addressing this roadblock, and then ultimately make sure that you're developing a plan to remedy any issues that you uncover. Now I'm going to go ahead and turn it over to Bill, who's going to walk through our case study example.
Great, thank you. And because of our confidentiality agreements, we cannot share specific examples. So this is an amalgamation of some projects we've had the chance to work on once we've overcome the roadblocks Charlotte mentioned. We're talking about Prairie Bridge Health System today. This is going to be a Midwest system about the same size, a lot of you in the audience, and they were looking at some very specific ways where they could impact patient outcomes. All right, so first of all, they looked at their data pipeline. This recording, I think, will be safe for everyone to look at. But going back to what Charlotte mentioned, like all healthcare systems, data coming in from a lot of places, from MyChart, claims data, lab data, social determinants of health, their patient portal, web analytics, social media analytics, call center analytics. The idea was to pull that pipeline into a single place, identify trends within that pipeline, build a patient model on how we could have the greatest influence on patient care, activate, get everyone from your marketers to your clinical practitioners to your finance folks involved in the activation, and then measure your success. In this case, getting that consensus, you've got to have the clinical staff on board. They've got to believe in the initiative. You've got to have marketing on board to communicate it. You've got to have IT and your security and compliance folks on board. You've got to have the analytics team. So making sure everyone supports it who's touching patient care, and making sure leadership understands the return you're aiming for and how you're going to mitigate risk. Ultimately, patients want to hear from other patients. And so all this comes down to developing patient stories about great clinical outcomes to build trust. In this case, we focused on congestive heart failure. The readmissions for this particular system were very, very high and expensive, which means two things: poor clinical outcomes and lower reimbursements. So identifying how can we improve both clinical and financial metrics. In this case, we understood what were those indicators that someone was likely to be readmitted, and then we developed actions. So everything from that teach back checklist when a patient is released from the hospital, to a mandatory 48-hour telehealth visit, to scheduling a week out clinic slot, and then using technology like sodium text to encourage sodium monitoring, and working with the pharmacist on MedSync. When something happened that took outside of the norm, having those triggers within the EHR or via text to say this person has reached a high risk area where they are likely to be readmitted, the outcome in this place was a great reduction both in readmissions and in ED visits. In this case, we go back to the ROI. How can we prove that we were successful? Well, we had the baseline discharges, and we knew about 20% of those folks were being readmitted, able to avoid 74 of those readmissions, which means more than $1 million in gross savings. When you look at what that program cost to implement, this was a 3.5x ROI on this investment. What did we learn? We started with a really specific problem, congestive heart failure. We got everyone on board, from clinical frontline to finance to marketing to the leadership. We picked an area where there was a high impact and a low risk, meaning we were pretty sure we could succeed because this was an area that was ripe for improvement, and then measured, learn, and change the program weekly as needed. With that, Charlotte and I want to thank you for your time. Our contact information is here on the board, and now we're going to switch over to the live panel and talk more with you. Thank you.
Awesome. Thanks, Charlotte and Bill. Charlotte, you outlined 5 major data roadblocks that healthcare organizations face. Would you be willing to expand a little bit on which of those challenges do you think has the greatest impact on a health system's ability to make data-driven decisions? And for our leaders here, how can they start addressing it starting now?
Absolutely. So I think there are 2 areas, but let's just cut to the chase. I think the single most important thing that we have to always protect is that patient trust, right? We have no data. We're not going to have access to data or permission to do things if we don't protect the patient trust. So that's where I would hone in on and focus first. And I think there are all of the policies and the processes that we have in place, right? We're going to say check to that. We know what those things are. We know what requirements have been placed before us and that we have to answer. What I would encourage all of us to do is look beyond the standard audit or the standard policy for the assumptions or the expectations that our patients or members may have of us in terms of how we're using their data that may not be stated as explicitly in a policy that we think. And I think that's a great place to start. And that goes to extending that transparency. Do our patients really, truly understand how we're collecting and using their data? I work with a lot of digital marketing, digital engagement teams, and we've addressed that a lot recently with the Office of Civil Rights guidance on how we collect data from websites and how we're utilizing that data to retarget and advertise to future patients and members. So it's still very much a hot topic, and it is continuing to expand. The other thing I would note too is not only is it transparency, but it's agency. Do patients or members understand how to manage their own data? Oftentimes in healthcare, it's a one-way street, right? I as a patient or member am giving my data to an organization and then trusting them where they're collecting data about me. But if I need something to change, if I want to communicate with you differently, if I need to tell you that, if something has changed with me that may not be collected in your record through your standard systems, how do I do that? How do I have agency as a patient or member to control the data that you're collecting about me?
Awesome. Bill, I've got a small question for you. So some of our other presenters have talked a little bit more about how specifically for maybe AI really directly we can we can start to affect scalable AI adoption. But we haven't necessarily talked how our healthcare organizations can ensure that their data infrastructure and their lot more wide-reaching governance policies can be strong enough to support that. Would you be willing to comment a little bit on what organizations can do to support responsible, scalable AI adoption?
Sure, absolutely. Yeah, I think it is a challenge. A lot of times when we start working with an organization, they go right to the end. They want the AI or the model. And we realize that within the organization, whether it's technical infrastructure, security policies, they're just not in a state. And so that prep work does matter. A lot of times it's really having a motivating, concrete example that you can get everyone behind, from the clinical side to the IT side to marketing to leadership. And you've got to talk the language of each of those stakeholders. So whether it's clinical outcomes or a higher ROI, but I think showing motivation, and AI, this has all happened so fast. There was this big wave, and now there's this little bit of a backlash, like this resistance, this hesitation, and can we really show value? And we've all seen the studies about what percentage of these initiatives fail. And so now we're seeing this like rapid adoption, and now let's put on the brakes a little bit. So I think looking for a low risk, high impact example where you can get large scale buy-in and adoption, especially when it comes from leadership, is the best way to get teams motivated to start working on that infrastructure so you can actually build the process.
All right, well, we're going to take this last one. Chris mentioned in the chat, how specific are some of these processes that you two have taken, specifically with your use case? Is there a lot of effort for the customization to be able to leverage some of these techniques in other areas?
Sure, I can talk for the example we gave you, the congestive heart failure. That what we did there. So you have adoption on the front side, the clinical treatment, those interventions, the telemedicine slot, the sodium checks. That could really be applied to just about any kind of readmissions challenge that you're having. So you've already got the adoption. Your interventions might look a little different. Your messaging, what you're looking for, your indicators. But I would argue when it comes to treating another readmissions challenge, very plug and play. If you're treating a completely different challenge, like analyzing length of stay or reducing ED visits for people coming with dental issues, you're probably building a whole new model. But when it comes to similar use cases, reducing readmissions, I would argue you could use the same model for readmissions for just about any condition.
All right. Well, thank you both, Charlotte, Bill. Appreciate you. I think we're going to bring in our other presenters. We've got a couple minutes to wrap this up, but I wanted you all to take a quick look at the poll that we had. We've got 40 people. And the question we had was, when deploying an AI chatbot for healthcare transparency, which of these would be most concerning to you? We've got almost a tie with data security and privacy, and then maintaining accuracy and avoiding hallucinations. I know we've kind of hit on this a little bit, but I'm going to open this up to the panel. Were there any things that you may have missed or that you wanted to really elaborate on how you've managed this in the past and how maybe some of our participants can think about this in the future? Maybe we'll start with Devon.
Sure. Yeah, it spoke a little bit to the security and privacy one already. I think no surprise there that it's the top item, and there are ways to architect solutions like what Dominic and I presented on to mitigate some of those risks, and it will limit you in potentially some of the models you have available in the solutions you're using if you want to really lock it down and keep it in your own infrastructure, or you can choose to partner with specific organizations and build that into your security risk model. I think the key is making sure you're not sending data all over the place and really broadening your risk profile for your organization.
Yeah, Ernie, you mentioned a little bit on that earlier today, and so Charlotte and Bill, just as a little bit of a question from you, taking it from a wider organizational standards, how do you start approaching this?
So I think what I would like to challenge all of us to consider in terms of how we approach this is oftentimes I think for a safety perspective, to make sure that we're staying secure and compliant, we default to no. And that's our standard, right? Our standard is no, because that keeps us safe. But it also limits innovation. And somebody mentioned, and I can't remember who it was, a gentleman, but we were talking about the opportunities for innovation and the possibilities for what's next for NAHDO for the next 40 years. And there was an encouragement to think creatively, right? There is a lot we can do even within the structures that are built around us to make sure that we stay safe. So I would like to encourage all of us to think about how can we say yes. That's and a lot of the work that I've done, it's figuring out how can we still get this done, and not let one roadblock stop you from moving forward. Find that creative way to still pull value, to still innovate, and to figure out how to say yes and not just stop it now.
We've got one from Cindy, a little bit about traditional quality control processes versus maybe human review of code, and possibly even AI review of code. So how do each of your organizations start to handle, as we bring in some of these AI processes into how we do work, in especially keeping the high quality alongside that AI, maybe code creation or SQL type creations? Ernie, would you be willing to talk on that one?
Yeah, we do manual review of everything that our ChatGPT gives us. So we do a lot of verification. We get a lot of issues just from, sometimes it's a little bit overwhelmed, and sometimes we're trying to define a patient population very narrowly, and it doesn't do that very well. So we are constantly doing a lot of manual review, even stuff that you would think it would be pretty old school, not questionable. It gets confused sometimes, and we have to go in there and manually adjust it. We don't really take any code that it gives us without running it back, usually through another analyst. So we have one analyst that reviews it, comes back, gives a suggestion. And then plus that way we have a meeting every Monday where we look at our models that we've done and we actually talk through it. And we say, here's a model that looks really good that ChatGPT suggested. What are the things? And we give points to people as they find these hallucinations and other types of quality issues. We start to reward our internal staff just to let them know that, we trust it, but we verify a lot. So I wish we didn't have to, but I think it's just, as we do that, it learns and becomes better. So some of the mistakes it made 2 years ago, it doesn't make anymore. So it's you have to put that human in there, I think.
Awesome. Well, thank you all. I really appreciate you being willing to come and talk about your AI experiences. I'm going to start to hand this back over to Norm. He hopped on, but wanted to thank you all for your time. Again, we'll work very hard to make sure we get questions answered for you all if you had extra ones. But all right, Norm, thanks.
Thank you. Thank you so much to our presenters, to Chaz for moderating, and also to our audience for just doing a fabulous job of feeding us good questions, thoughtful questions. And so like Chaz mentioned, we are going to try to get answers to all of those questions, even the ones we weren't able to do live. We'll get written answers. We'll put those back over there on the same chat. This will remain available throughout the conference, and also the recording of this session will be available throughout the conference. So coming up next, we have more breakout sessions at 2:50 p.m. Eastern. So we'll take a short 10-minute break, and we will be back at it with more exciting questions and presentations. Thank you, everyone.